Hello. Is this mic working? Yeah, it seems like it's working. Good afternoon, everyone. It is a true pleasure to be here. Thank you for that kind introduction. The first time that I spoke at this conference, I talked about what we wanted to do. The next time I spoke at this conference, I talked about what we were doing. So it's a real pleasure to be able to come back today and actually show you some results finally. So excited about that. All right. These are my disclosures. If you were to ask me as a neuro-oncologist what keeps me up at night, I would say it's this photo right over here. This is an autopsy case study by Matthias Nuderl of a patient with glioblastoma. And what it shows is that at the time of death, this patient's tumor had spread far beyond its original location. It spread clear across to the other side of the brain. Not only that, there are tentacles of tumor cells that are infiltrating far beyond what you can see on even the MRI scan. Now, we've known for a long time that glioblastoma can do this. Actually, back in the early days of neurosurgery in the 1920s, the pioneering neurosurgeon Walter Dandy over at Hopkins would do full hemispherectomies on patients with glioblastoma. But what do you think happened? The tumor just came back on the other side. What Matthias showed in this study is even more frightening. What he showed is that not only does the tumor infiltrate all over the brain, but that different parts of the tumor are activated by different genetic alterations. Meaning that even if you had a treatment that could successfully target treatment in one area of the tumor, no guarantee that it would have any effect whatsoever on other areas of the tumor whatsoever. This tumor is a nightmare. So how do you treat this? How do you treat something that hides in amongst the normal cells of the brain? How do you treat something that shapeshifts every time you try to do something to it? Well, we've tried many things. We've tried anti-angiogenic therapy, targeted therapy, immunotherapy. As a field, since 2005, there have been 16 phase 3 clinical trials for patients with glioblastoma. All of them except for one was negative. That one trial was a modest success. That was Tumor Treating Fields. So, as you can see, this is really not the best track record that we have here. This is a quote from the journalist Alfred Henry Lewis. Back in 1906, he wrote, "There are only 9 meals between mankind and anarchy." Incidentally, he wrote this in Cosmopolitan, which was apparently a different sort of magazine back then. But what he meant by it, and what people oftentimes use this quote to illustrate today, is this idea that even though it seems like we have, the fancy trappings of modern day society, we're really not all that far from complete social breakdown if people's needs aren't being met. I think there's 2 other points of this quote that I'd like to just point out. One is that it shows how sacred our relationship with food is. Food is, of course, a need. Food nourishes us. Food comforts us. We put our hopes and dreams, our fears and anxieties in the food choices that we make. And when I talk to patients about their brain tumor diagnosis, very often one of the first questions that they ask about is, what can I do with my diet? The other point I'd like to make is, I'm sure not something that Mr. Lewis had in mind when he wrote this, and that is to say that I think you could apply it to tumors as well. As scary as glioblastoma is, it's not the boogeyman. It can't just arise out of nothing. When tumor cells grow, they have to meet the same sort of energetic and synthetic demands that any cell needs to grow, and it has to use basically the same metabolic pathways to do so. In other words, glioblastoma, as indestructible as it seems, maybe we're not actually as far away from having an effective treatment as it sometimes seems. Now, there's been a lot of wonderful research done in recent years, including some research shown here today, that illustrates that it is indeed possible to take a metabolic approach to the treatment of at least some cancers. I'm going to skip over all of that science today, not enough time. But instead, I'll take up the story basically where it started for us. And that is with these 2 people. So on the left is David Shevik. When Dave was diagnosed with glioblastoma in 2015, one of the first questions he asked me was, hey, what about a ketogenic diet? I heard that it might be helpful for patients with brain tumors. And I did what I normally did in a situation like that. I told Dave, I don't know too much about it. Let me send you to the oncology dietitian fully expecting that the dietitian would do the same thing that they've always done up to that point in time when I referred patients to them, which is to say, you know what, there's not too much evidence, it's a difficult diet, you should just stay on a standard diet. What I didn't realize was that Cedars had hired a new dietitian. That's LJ Amaral that you see over on the right. And so when Dave approached her and said, you know what, I'm interested in a ketogenic diet, she said, sure, let me help you with that. Now, one thing about both Dave and LJ is that you could describe them both with the adjective dynamic. So next thing I know, I'm sitting in a conference room on a Saturday morning with a bunch of my patients, and we're all deciding to go on the ketogenic diet together. So we all went on this ketogenic diet, just this kind of hodgepodge bunch of patients, and me, and we all went and did it together. And of course, at the end of it, we celebrated with a keto cake, right, that you see there. Now, keep in mind, this was not a clinical trial, so it really was kind of a random hodgepodge of patients. There were patients who participated in this project who had low-grade gliomas. There were other patients who had glioblastoma. Some patients had just recently been diagnosed. Other patients had been through multiple lines of therapy. There were some patients who were on other treatments at the time and other patients who weren't on any other treatments at all. And let me be very clear that as a veteran of all those failed clinical trials, I was expecting nothing at all. And so imagine my surprise when a couple of weeks into this whole experiment, patient after patient started coming into our office saying, hey, you know what? I feel a bit better. My energy has improved. My mood has improved. I can think a little bit more clearly. My seizures don't seem to be happening as frequently as they were before. Now, for some of these things, certainly there can be a subjective component to the reporting of it and the experience of it. But there were other things that were hard to just chalk up to that. There was one patient who told us, you know, I couldn't read anymore. And all of a sudden, after being on this diet for 2 weeks, I can read again. And then we started to get some MRI scans like this. So this is a patient with recurrent glioblastoma. This is the real deal, very bad. On the left, you see that bright contrast-enhancing tumor. And after being on a ketogenic diet for 2 months, you can see that there's significantly less contrast enhancement. This is a patient with a spinal cord astrocytoma. On the left, you can see before keto. On the right, after keto. And what you see is that there's a significant reduction in the size of the tumor after being on the ketogenic diet. This patient was not on any other therapy. This was diet alone. This is a patient with a grade 2 oligodendroglioma. So this is a low-grade tumor. This patient had just recently been diagnosed and so was also on chemotherapy and radiation therapy. But to be clear, usually the best that we hope with chemotherapy and radiation therapy is to stabilize the tumor, maybe shrink it a little tiny bit. This type of result, the shrinkage that we see here, is really not something that we see every day. This patient developed a recurrence of glioblastoma. We noticed it when we got that scan on the left. We saw that new bright area of showing contrast enhancement. And he actually signed up for a clinical trial. Now, that clinical trial had a little bit of a waiting period for it. So what he said was, well, in the meantime, let me just try this ketogenic diet thing. He went on a ketogenic diet, and then just 20 days later, as part of a baseline study for the clinical trial, he went ahead and got the MRI. Again, in that 20 days, all he had done was implement a ketogenic diet. And you can see in that middle panel, again, a significant reduction in contrast enhancement. Interestingly, his next MRI scan after he had started the trial showed really complete resolution of contrast enhancement. Again, this is not something that we typically see. So these results are really intriguing and really exciting to me. But we knew what we had to do next. You know, we know that to change clinical practice, it's not enough to just invite a bunch of patients to do the ketogenic diet with you. You actually have to conduct a formal clinical trial. And so that's what we moved forward with. So we opened a single-arm phase 1 clinical trial of a 16-week ketogenic diet in combination with standard of care, so that's temozolomide chemotherapy with radiation therapy, for patients who had recently been diagnosed with glioblastoma. Now keep in mind, this is a phase 1 trial. The goal of a phase 1 trial is to just get a few patients, enough so that you can determine safety and feasibility, it's not enough patients typically to really get a clear sense of how effective a treatment is, but you have to start somewhere, so this is what we started with. This is the trial design. Again, we allowed patients to enroll in this trial anywhere from 12 weeks from diagnosis. We followed patients very closely. We monitored blood glucose and ketone levels twice a day. They uploaded their data into a portal, and our dietitian would talk to them on a regular basis just to go back and forth in terms of how to best manage the diet. We gave every patient Fitbit monitors so that we could monitor their steps, their activity level, their sleep. We also performed regular assessments of cognition and quality of life. And then we also performed a whole host of exploratory studies looking at cytokine panels and inflammatory markers, looking at metabolomics over time, and also looking at exploratory studies of the microbiome as well. So our experience was interesting. The moment we opened this study, before we even had a chance to publicize it at all, we started getting phone calls. We started getting phone calls from people all over the country asking about this study. It was amazing just the level of interest that there was in this patient population when it comes to a ketogenic diet. Our initial goal for this trial was to enroll 20 patients. The COVID pandemic did interfere with that a little bit. So after we had enrolled 14 evaluable patients, we went to our study statistician who looked at all the data and said, you know what, you've already met the primary objective of the study, you've shown safety and feasibility, let's just go ahead and close the study. So we closed the study at that point in time because the objectives have been met. Median age on this study was 55. The median Karnofsky performance status was 85, which is good. These are highly functional patients at baseline. 8 of these 14 patients were women. One thing to keep in mind is that all but one of these patients was a non-Hispanic Caucasian. I do think a point of emphasis moving forward in studies like this is that it is very important to try to make sure that underrepresented groups are enrolled as well. About half of the patients had had surgery with a complete gross total resection of the tumor, which is microscopic residual disease. About half of them were on steroids at baseline. About half of the tumors had a methylated MGMT promoter, and all but one had a wild-type IDH1. All of those characteristics are pretty much in keeping with the general glioblastoma patient population. So what did we see? Well, it seemed like patients actually tolerated the diet quite well. We monitored their adverse events, and we did see one patient who had a grade 3 constipation. This is a patient who also was on chemotherapy at that time, and the chemotherapy itself also causes constipation. So it's difficult to adjudicate exactly what's causing what. But for the most part, you can see that the effects of all the treatment combined were fairly mild, grade 1 and 2 in nature. So patients did have loss of appetite, nausea, some with flu-like symptoms, and some with fatigue. But again, all pretty much mild and manageable. And again, it's hard to say exactly how much of that was related to the ketogenic diet versus not. When we were designing the study, we thought to ourselves, you know what, these are patients who are coping with a new diagnosis of glioblastoma. They'll also be getting radiation therapy and chemotherapy. This is going to be really hard for them to stay on. So if just half the patients can be in ketosis half of the time, we'll consider that a success. Well, we're definitely happy to see that not half the patients, but actually all the patients were able to be in ketosis at least 50% of the time. And 11 of the 14 patients were actually able to maintain ketosis 85% of the time. Another important safety measure that we wanted to take a close look at was weight and BMI. Many patients did lose some weight on this study, but there was no instances of excessive weight loss. We also looked at the ketones both in the morning and in the afternoon. I guess you can kind of see the light gray in the background. The light gray in the background of these charts is basically the individual patient trajectories, and the dark line is the mean averages of the ketone levels. A couple things to note here. One is that there is a tremendous amount of individual patient variation. There were some patients who were very consistently in the 2 to 3 millimolar ketone range with peaks that were even higher. There were other patients who had a hard time getting to that point and who hovered more around the 1 millimolar range of ketosis. Another thing that you'll notice on these charts is that the lines are pretty flat. And most notably, patients were in ketosis at day 0. Day 0 was supposed to be when they started the diet, and they were already in ketosis. So what's going on there? Well, of course, what happened was the moment that we would talk to people about this clinical trial that they could potentially participate in, before we had a chance to confirm eligibility, before we had a chance to do all the education that we had planned, they went home right away and they started doing what they could right away. And so that day 0 baseline isn't a true baseline of before being on a ketogenic diet, because they had already gone to efforts to start things themselves, which is great as far as having patients who are so eager to adopt an intervention. Not so great as far as being able to compare back to a baseline that's before the diet intervention. Now, one metric that's thought to potentially be important to look at is something called the glucose ketone index, which is basically glucose in millimolar divided by ketones in millimolar, with the idea that the lower the glucose and the higher the ketones, that's really where you want to be. And theoretically, potentially, somewhere of a glucose ketone range, somewhere in the range of less than 3 or maybe even less than 2, would be ideal for a therapeutic effect. Now, we did not pre-specify any target GKI goals for our patients, but we did assess it. And what we could see is that GKI less than 3 was hard for patients on this study to kind of meet just with the intervention that we did here. There was one patient who had a GKI less than 3 over 80% of the time, but for several of the patients, it really was kind of beyond their reach. Keep in mind, of course, many of these patients were on steroids. Steroids certainly elevates the glucose levels to a degree, and again, can make that goal GKI a bit hard to reach. Now, again, this study, small phase 1 study, not powered to look at efficacy, but we did see some interesting things. This is a patient where you see the preoperative scan on the left, the postoperative scan in the middle, and then on the right is the post-treatment. So that's with radiation, chemotherapy, and a ketogenic diet. And what you can see is on the top is basically the post-contrast view. And what you see on the top right is that after treatment, there's really no visible contrast enhancement at that point. On the bottom is an MRI sequence called FLAIR. FLAIR looks at a lot of things, but one of the things it's very good at looking at is at edema or swelling and inflammation in the brain. And again, you can see after treatment, there's almost complete resolution of that FLAIR signal, a lot of improvement in the edema that we see. In a subset of patients, we also performed some exploratory imaging studies. On the left is dynamic contrast enhanced MRI scan. If you focus on that K-trans box before and after treatment, K-trans is a measure of vascular permeability. So you can see after treatment, it looks like there's less signal, less vascular permeability than you see before treatment. And one of the thoughts with treatments like anti-angiogenic treatments is that they're able to decrease K-trans by normalizing the blood vessels, and maybe that has a therapeutic benefit. On the right is an image from a PET MRI scan. This is a fluorodeoxyglucose PET scan. So what we do is we inject a radio-labeled fluorodeoxyglucose. And of course, the idea being that cancer cells are very avid uptakers of glucose, and so that you'll see a bright spot where the tumor is. Now, traditional PET scans aren't actually that helpful in the brain, because it turns out that a lot of the brain is very glucose avid, and it can be hard to really differentiate what's taking up the glucose. Is it the normal brain, or is it the tumor? But when you co-register it to an MRI scan, then you can get a much clearer sense. And what you see in that image is what's kind of glowing yellow. That's the normal cortex, normal tissue, taking up a lot of glucose. But you can see where that arrow is pointing, that contrast-enhancing tumor. There isn't that yellowish glow. There is no hypermetabolism in that area of tumor in this patient on a ketogenic diet. We did look at serum IGF-1 and insulin levels over time. And it does look like in this patient group that IGF-1 levels did seem to decline over the course of the study. Insulin levels did not. Insulin levels looked kind of flat, and then maybe even actually went up a little bit later. Again, a lot of caveats to this. This is small numbers. These are patients who are on steroids and chemotherapy and radiation therapy. So hard to know exactly what to make of all of this, but we took a look at it. We're still in the process of doing all the metabolomics analysis and also looking at the microbiome. I'm fortunate to work with some really great collaborators who've done work in other disease areas on this topic. So what you see on the left is some work by Ashley Chi and Steve Friedland. And they did actually a prostate cancer study where they gave men with prostate cancer a low carbohydrate diet. It was not specifically a ketogenic diet, but there were some patients who ended up in ketosis. And so when they did their metabolomic profiles, what they did is they looked to see the level of these ketone metabolites and showed that the higher the ketone metabolites correlated with a longer PSA doubling times. On the right is some work from Stephen Shao, another close collaborator. His lab actually just published a big cancer cell paper looking at the role of the microbiome and its influence on modulating immunotherapy. And his lab has also done some work showing that the ketogenic diet also modulates a response to immunotherapy and changes basically the composition of the microbiome. And of course, we looked at survival. We looked at progression-free survival, we looked at overall survival. This is, again, a phase 1 study, small, not powered to look specifically for efficacy in comparison to anything else. But the numbers that we got were very encouraging. So if you compare to the phase 3 EORTC NCIC trial, that was the trial that defined temozolomide as basically the current standard of care, so we often do compare back to that. Patients on our clinical trial had a 70% improvement in progression-free survival and almost a doubling of median overall survival. Again, this comes with all the caveats. This is a small trial. These are very motivated patients who participated in this study. On the other hand, is this exciting? Yeah, this is really, really exciting. And if this were a drug that showed this number, there would be a lot of very excited investors out there for sure. So what have we learned? Well, we've learned that the ketogenic diet in this patient population of newly diagnosed glioblastoma is indeed safe and feasible to give. It is worth noting that this does require a lot from patients and caregivers. This is not easy. Again, fortunately, we have extremely motivated patients who want to do this, who like the idea of being able to do something for themselves when they have this disease, but it is a lot of work. Similarly, it's a lot of work for the dietitians and for the research coordinators to be able to really manage patients on a daily basis. Another thing we learned, as you saw, is that patients can't wait to start, so that does affect the baseline data to some degree. Another thing that's worth noting is that there is variability in outcomes. The ketogenic diet, the way that we implemented it in this trial, it's not a home run. There were some patients who did really well, but there were other patients where it's hard to know if it really did much of anything. Not every patient did extremely well. But it is easy to find patients. Now, for a long time, there wasn't much in the literature to guide us as far as using the ketogenic diet for patients with brain tumors. It was limited to case series, case reports. And that was pioneering work, to be sure, but it certainly didn't leave us with much to be able to move forward with. Fortunately, that is starting to change. So in the past several years, there actually have been a number of these small clinical trials now of a ketogenic diet or something related to that for patients with brain tumors. And of course, we can now add the trial that we conducted to this list as well. And of course, it's really not fair to compare small trial to small trial. It's really not the point of this. But what I will say is that from our trial, I'm encouraged by the high level of adherence that we saw. Not all the other trials saw that. And also our preliminary survival numbers also looked very promising as well, and not every trial saw that either. There are still a lot of questions, more questions now than what we had at the outset. The main one still being, is the ketogenic diet effective as an anti-cancer treatment for patients with brain tumors? We still don't know. We still need to show that with a trial that's specifically designed to be able to show that. If there is a benefit to the ketogenic diet, what does it come from? Is it the glucose lowering? Is it the ketones themselves? Is it a combination of everything and its effects on physiology? All of those things still have to be worked out as well. What level of ketosis is optimal? We don't know that either. What other therapies should we combine with the ketogenic diet? Should it be other metabolic therapies, targeted therapies, immunotherapy, kind of all of those things put together? Again, a lot of different things that need to be sorted out still. There are really too many questions to answer in one trial, but we do have to start somewhere. And so what we are planning is a multi-center randomized phase 2 study of standard care with or without an 18-week ketogenic diet for patients with newly diagnosed glioblastoma. Our accrual goal is 170 patients at 5 sites over 2.5 years. This would be the first brain tumor clinical trial that I'm aware of that would be really sufficiently powered to look at this efficacy question, which is so, so important. Lastly, there are too many people on this list to really thank individually. What I will say is that this has been a labor of love for a lot of people, and that we really couldn't have done it. I'm so privileged to work with these wonderful, hardworking, and talented people. I would like to specifically thank Angela and Victoria and Dom for all their help, not in just putting all of us together here, but also in supporting our project and our work specifically. So thank you for that. And lastly, I do want to thank our patients and their families. Our work is, of course, for them. We couldn't do it without them. This is Jacob Crooks. So Jake was one of the patients who was at that Saturday morning conference. He was just 25 when he was diagnosed with glioblastoma. And for a long time, he actually did quite well. For a long time, he would come to the clinic visits with absolutely no complaints. And so we would spend most of our time talking about philosophy. I remember one day walking into clinic and seeing he had a book in his hand. And I asked him, hey, what book is that? And he said, St. Augustine. Like, that's a normal book for a 25-year-old to be reading. Unfortunately, by the time the keto project rolled around, he wasn't doing so well. So his tumor had started to grow at that point in time. He didn't have much energy. He was spending most of his time in the house. He wasn't really getting dressed all that much. He really wasn't talking about philosophy much at that point in time. So again, imagine my surprise when 2 weeks later, he comes to my clinic, and it's like the hands of time have been turned back. He's well-dressed, he's making jokes, and it was just so moving to see him be able to interact with his family, you know, the way that he used to. The ketogenic diet, again, it's not a cure-all for glioblastoma, at least. So a few months after that, his tumor did grow again, and he died shortly afterwards. But when I called his mother and to offer my condolences, what she said was, thank you. Thank you so much for giving us a magical summer. There were 3 weddings that summer that he really wanted to go to, and he was worried that he wasn't going to make it. And not only was he able to attend, but he was able to just be with everyone. He was able to laugh, he was able to dance, he was able to be himself with all of his loved ones. And so I'll just conclude by saying, I hope we can make many more magical summers, and we have a lot of work to do.